Hi doctors. It's me again, Pearl. In this video, we'll be tackling the cardiovascular section of adult health in the AMC MCQ Handbook. There are only 15 questions in this section, but I hope it'll all be high yield. Let's start. An 84-year-old woman attended the emergency department with a history of retrosternal chest pain, radiating to the back, associated with sweating. She says the pain is a very severe and sharp deep pain worsening over the past 3 hours. On examination she is distressed and in pain, pulse is 100 beats per minute and regular, and her BP is 180/90 mm mercury. Heart sounds are normal. Her past history includes hypertension treated with ACE inhibitors, and type 2 diabetes treated with metformin. ECG shows ST depression in V5 and V6. Her chest X-ray is illustrated. Which one of the following is the most likely diagnosis? A. Pericardial effusion. B. Carcinoma of lung. C. Myocardial infarction. D. Aortic dissection. E. Sarcoidosis. In an elderly woman with comorbidities, who presents with chest pain, the most common cause that one can think of is acute coronary syndrome. However, in this case it is characterized that the pain is radiating to the back, coupled with an X-ray that shows a widened mediastinum. In this case, we should rethink our primary diagnosis and consider aortic dissection instead. It is relatively uncommon, compared to myocardial infarction, but has to be recognized to avoid serious consequences. With the scenario as described, the widening of the aorta on the chest X-ray should be diagnostic. D is correct. Take note that a pre-existing aortic aneurysm is a risk factor. A CT of the chest should confirm aortic dissection. A. Pericardial effusion is not seen on the chest X-ray. C. The ECG finding of ST depression in V5 and V6 is not diagnostic of myocardial infarction. For choice B and E, the mediastinal widening does not suggest carcinoma of the lung or sarcoidosis. In contrast, the X-rays should look like this respectively. A 57-year-old man with a 40-pack-year smoking history presents with a 2-month history of episodes of a gripping acute pain in either calf which often wakes him from sleep. To relieve the pain he gets out of bed and walks about. The patient also has type 2 non-insulin-dependent diabetes controlled by diet. Which one of the following is the most likely diagnosis? A. Muscular cramps. B. Ischemic rest pain. C. Peripheral neuropathy. D. Deep venous thrombosis. E. Intermittent claudication. Acute gripping nocturnal calf pain is a common clinical condition of middle age, associated with muscular cramping and spasm, such that the pain is associated with a firm, painful knotting of the affected calf. Take note that the pain is acute in onset, eases over a few minutes, and that relief is obtained by getting up and walking or extending the ankle and foot. Although the patient has comorbidities, muscular spasm has no specific association with systemic illness or vascular disease. A is the answer. This may be hard to differentiate from ischemic rest pain given the nocturnal presentation and comorbidities of the patient. However, ischemic pain is described to be intense, burning or throbbing pain felt peripherally in the foot and toes, often worse at night. It's important to note the presence of other symptoms of chronic limb ischemia suggestive of tissue loss like ulceration, gangrene, necrosis. Peripheral neuropathy is common in diabetes, and is associated with paresthesia in the leg, with tingling, pins and needles and burning discomfort, often of glove and stocking distribution. Deep venous thrombosis or DVT can cause symptoms of deep-seated calf pain and tenderness, with or without other stigmata of edema, color change, unilateral discrepancy, and systemic effects of fever and tachycardia. Intermittent claudication pain is precipitated by exertion, and as defined does not come on at rest. A 56-year-old man presents with a 6-month history of pain in his right calf. The pain is brought on by walking and was initially eased when he stopped. More recently he has experienced rest pain in the right leg, particularly at night. He smokes 40 cigarettes a day. On examination his BP is 150 over 100 mm mercury. His right femoral pulse is diminished and the right dorsalis pedis pulse cannot be felt. His ankle brachial BP index is 0.3, normal ratio is 1. Urinalysis is normal. Which one of the following is the most appropriate plan of management? A. Stop smoking, encourage exercise, review in 3 months. B. Stop smoking, encourage exercise, prescribe pentoxifylline. C. Stop smoking, encourage exercise, prescribe an ACE inhibitor. D. Arrange duplex Doppler venous studies and review. E. Arrange an arteriogram and review. Nocturnal pain of the limb, coupled with chronic smoking, a risk factor for developing peripheral artery disease, raises our suspicion of chronic limb ischemia for this patient. If this patient's problem was only ischemic intermittent claudication, then conservative measures including cessation of smoking and encouragement of exercise would be beneficial. However, active intervention is required so as not to lose his limb. Most important management is that this man warrants an arteriogram and further assessment, since this patient may be needing a more definitive management like revascularization. E is correct. For choices A, B, and C, it is likewise important to persuade the patient to stop smoking, to treat his hypertension, and check his lipid profile and blood sugar. There may be a role for pentoxifylline, but only a moderate benefit is provided by this drug. D. Duplex Doppler venous studies will not identify an arterial blockage, instead it's useful for venous pathologies. You can read more on the indications of surgical intervention for peripheral artery disease in the RACGP guidelines. I'll post the link in the comments section. A 62-year-old woman is seen in the ward 24 hours following a non-ST segment elevation myocardial infarction. She complains of lightheadedness. The radial pulse rate is difficult to feel, BP is 90/60 mm mercury, heart sounds are muffled and there is evidence of biventricular cardiac failure. Which one of the following rhythm strips shown would be of most concern in this situation? Is it Rhythm strip A? Strip B? Strip C? Strip D? Or strip E? It is very important to note that the patient is presenting 24 hours after an acute non-STEMI. A time when patients are at increased risk of cardiac arrhythmias, and particularly concerning are episodes of ventricular tachycardia, as illustrated in rhythm strip A, showing a rate of 180 beats per min. This may be associated with hemodynamic compromise, and require urgent cardioreversion. Rhythm strip B atrial fibrillation would exhibit an irregular pulse rhythm. The case is not consistent with the rest. Strip C is atrial flutter. Strip D is supraventricular tachycardia. Strip E is a heart block, where not all P's is followed by QRS wave, signifying a block of the signal from the atrium to the ventricle. A 28-year-old man develops rapid palpitations and mild lightheadedness following a 20 km run. He is not known to have cardiac disease and a recent cardiovascular examination was normal. The pulse is rapid and regular. Which one of the following rhythm strips would be most likely with this clinical picture? Is it rhythm strip A? Strip B? Strip C? Strip D? Or strip E? An episode of rapid palpitations in a young patient following strenuous exercise is most likely due to an episode of paroxysmal supraventricular tachycardia. The answer is D. Rhythm strip A is ventricular tachycardia, which is less likely in the absence of any cardiac disease. Rhythm strip B atrial fibrillation, as this patient has regular rhythm. Rhythm strip C atrial flutter could also actually be the answer, as patients may also present with symptoms of palpitations, lightheadedness, fatigue, and shortness of breath. Although the handbook states D as the answer, in actuality, determining whether it is SVT or atrial flutter could only be done by obtaining the patient's actual ECG. It worth mentioning, however, that atrial flutter is a common complication of hypertension and hypertensive heart disease, making it uncommon in a structurally normal heart. Rhythm strip E heart block would not cause rapid palpitations. A 66-year-old man has long-standing hypertension, which has been well controlled on a combination of perindopril and amlodipine. He presents for a routine clinical visit and physical examination is normal. His BP is 144/70 mm mercury and pulse is regular. An ECG is taken. Which one of the following rhythm strips would be consistent with this clinical picture? The same set of choices is shown. As mentioned earlier, patients with hypertension who are asymptomatic can still have an arrhythmia, in particular an atrial flutter. C is the answer. A 28-year-old man has had 8 episodes of palpitations associated with mild dizziness and sweating over the past year. These came on suddenly, usually after exercise, and have lasted between 10 and 20 minutes, often stopping after putting his face in cold water. He now presents with an attack that has been going for 2 hours and he is mildly distressed. His ECG is shown. Which one of the following therapeutic agents is most likely to be effective? A. Digoxin. B. Quinidine. C. Flecainide. D. Verapamil. E. Propranolol. The recurrent arrhythmia is most likely to be that of paroxysmal supraventricular tachycardia, as demonstrated by his current ECG, which shows a regular tachycardia at a rate of 180 per minute. Paroxysmal supraventricular tachycardia may be managed by maneuvers that increase vagal tone by immersing the face briefly in cold water, something he had discovered. Other methods include carotid sinus massage, but caution is required in the elderly, being wary of dislodging a carotid thrombus, and the Valsalva maneuver. If these are ineffective, the first-line therapy is either adenosine or verapamil given intravenously. D is correct. This will restore sinus rhythm in most cases. If unsuccessful at first use, maneuvers to increase vagal tone can be repeated, followed by further bolus injections of verapamil or adenosine. Other second-line agents include the beta-blockers like propranolol and flecainide. If attacks are frequent, prophylactic oral therapy with verapamil, beta-blocker, flecainide or amiodarone may be considered. Digoxin is rarely used and quinidine should not be used. Patients with a variety of cardiac conditions may require special care in pregnancy. Which one of the following heart lesions present during pregnancy is most likely to cause problems? A. Mitral stenosis. B. Tricuspid regurgitation. C. Mitral regurgitation. D. Aortic regurgitation. E. Ventricular septal defect. Mitral stenosis is the heart lesion most likely to cause problems in pregnancy. A is the answer. This can lead to pulmonary hypertension and pulmonary edema, especially in a pregnancy where there is increase in blood volume, cardiac output, and elevation of the pulse. There is also an increased risk of atrial fibrillation and tachycardias. In contrast, regurgitant mitral, aortic, tricuspid valvular diseases and VSD are generally well tolerated in pregnancy. You really won't get this question wrong as the answer is already very obvious. Just remember this mnemonic. Don't miss MS or mitral stenosis among misses. Miss MS. Misses for mitral stenosis. In which one of the following conditions would silent painless myocardial infarction be most common? A. Polycythemia vera. B. Hypertension. C. Diabetes. D. Migraine. E. Hypercholesterolemia. Atypical symptoms of myocardial infarction include fatigue, weakness, and syncope. This occurs more commonly in older patients and in patients with diabetes. C is correct. Cardiac autonomic neuropathy is thought to be a contributing factor to the silence in this disorder. Hypertension is the most important preventable risk factor for which one of the following disorders? A. Coronary artery disease. B. Peripheral arterial disease. C. Renal arterial disease. D. Ischemic stroke. E. Atrial fibrillation. Hypertension is a major risk factor for coronary artery disease, and treatment of hypertension reduces the risk of coronary artery events by about a third. But the most important reversible risk factor for coronary artery disease is hypercholesterolemia. Remember, C is for C. Hypertension is a major risk factor for peripheral arterial disease. Treatment of hypertension can reduce the risk of developing peripheral arterial disease, but the most common and important risk factor for peripheral arterial disease is smoking. Remember, PAD is for pipe. Hypertension can cause intraluminal thickening of the renal vessels and eventually chronic renal failure. Preventing hypertension may be effective in lowering risk for renal disease, but the impact is less than the answer, which is D. The link between blood pressure and stroke is clearly a linear association, and hypertension is the single most important reversible risk factor for ischemic stroke. It is even more strongly associated with the risk of hemorrhagic stroke. The answer is D, stroke. Remember, elevated BP for B, brain or stroke, may it be ischemic or hemorrhagic. Hypertension and hypertensive heart disease, with the development of left ventricular hypertrophy and diastolic dysfunction, is an important risk factor for atrial fibrillation. A patient with aortic stenosis has had a heart catheterization. You are told that the aortic systolic gradient is 55 mm mercury. Which one of the following additional pieces of information is necessary to determine the significance of the gradient? A. Presence of coronary artery disease. B. Left ventricular ejection fraction. C. Left ventricular end diastolic pressure. D. Cardiac output. E. Left atrial pressure. An aortic systolic gradient of 55 mm mercury means that during systole the pressure in the aorta is 55 mm mercury lower than the pressure in the left ventricle. A normal gradient is less than 10 mm mercury. If the cardiac output is normal, then a gradient greater than 50 mm mercury is an indication for surgery. If the cardiac output is reduced, for example as a result of ischemic cardiomyopathy or cardiac failure, then a gradient of 55 mm mercury is even more significant and indicates very severe aortic stenosis. D is the answer. Carotid output, once becomes reduced due to stenosis, increases the gradient between the aorta and left ventricle, not A, B, C, nor E. Moving on to a stem on the vascular system. Which one of the following joint injuries is most likely to produce an arterial injury? A. Anterior dislocation of the shoulder. B. Lateral dislocation of the ankle. C. Posterior dislocation of the knee. D. Anterior dislocation of the elbow. E. Posterior dislocation of the hip. Traumatic posterior dislocation of the knee is particularly liable to be complicated by popliteal artery injury. The answer is C. Shoulder and hip dislocation are each at risk of nerve injury. The rest of the joint injuries are less of a cause of arterial injuries. A 73-year-old woman with COPD and a long history of cigarette smoking is admitted with a history of fever, cough with yellow sputum, and chills for the past 5 days. On examination, her temperature is 38 degrees Celsius, BP is 120 over 70 millimeters of mercury, and pulse 98 beats per minute. There is bilateral wheezing. Her chest X-ray is shown. Which one of the following is the most appropriate next step in diagnosis? A. Sputum microscopy staining for acid-fast bacilli. B. Sputum microscopy with gram stain. C. A bronchoscopy. D. A sputum microscopy for Aspergillus fumigatus. E. CTPA. The history is suggestive of an acute infection in the lung. This could be a lower respiratory tract infection or an exacerbation of chronic obstructive pulmonary disease. The chills and fever should alert the clinician to the likelihood of bacteremia or systemic inflammatory response. The chest X-ray shows a consolidation in the right upper lobe, and the diagnosis in view of the history is right upper lobe pneumonia. The immediate bacteriological investigations are blood cultures and sputum microscopy with gram stain and cultures. B is correct. If the pneumonia does not respond to appropriate antibiotics, one would think of tuberculosis or tumor and investigate this patient accordingly by bronchoscopy and search for tuberculosis and acid-fast bacilli on microscopy. Aspergillus fumigatus infection tends to attack previously diseased upper lobes and often forms a mycetoma. There is no suggestion of a pulmonary embolism here, and so a CTPA will not be the investigation of choice. A 66-year-old man presents to the emergency department following 3 episodes of mid-sternal chest discomfort, each lasting between 3 and 5 minutes, over the last 72 hours. The discomfort came on at rest and was relieved after 2 puffs of glyceryl trinitrate spray on each occasion. 2 years ago, he had been commenced on metoprolol following an episode of exertional chest pain. He stopped smoking 2 years ago, had well-controlled hypertension and was on treatment for hypercholesterolemia. A recent plasma total cholesterol was 5.5 millimoles per liter. His drug therapy was aspirin, perindopril plus indapamide, metoprolol, atorvastatin. An ECG showed left ventricular hypertrophy and lateral T-wave flattening. Serum troponin was normal. Which one of the following is the most appropriate next step in management? A. Increase metoprolol to 100 mg twice daily. B. Increase atorvastatin to 80 mg daily. C. Commence clopidogrel 75 mg daily. D. Commence intravenous glyceryl trinitrate. E. Commence subcutaneous enoxaparin twice daily. Note the pertinent findings in this case. This patient fits into the intermediate risk category of non-ST segment elevation acute coronary syndrome because of the following features. Chest pain or discomfort within the past 48 hours that occurred at rest, or was repetitive or prolonged. Age over 65 years. No high-risk changes on ECG. 2 or more risk factors, hypertension, hyperlipidemia, and past smoking. Prior aspirin use. He requires admission for further diagnostic evaluation and further risk stratification, with frequent ECG monitoring and repeat troponin testing. Given that he is at high risk of coronary artery disease, it is very appropriate to commence subcutaneous enoxaparin therapy. E is the answer. Although there is irrefutable evidence for beta-blocker therapy in the treatment of ACS, further evaluation of his heart rate is needed before considering increasing his metoprolol therapy, as he may already be on an adequate dose. He will need an increase in his atorvastatin therapy in the intermediate term, with a target LDL cholesterol level of 2 millimoles per liter. This is not, however, the most important next step in management. The use of clopidogrel in acute coronary syndromes is appropriate early treatment in high-risk patients, but should not be given immediately in this patient, who may well go on to early coronary angiography. Intravenous glyceryl trinitrate is used in the setting of refractory pain, which is not applicable in this case. A 65-year-old man with atrial fibrillation presents with sudden onset of pain in his left leg. On examination, his leg is cold and pale. There are no pulses palpable in the leg, and he finds it difficult to move his leg. He is a non-smoker. Which one of the following is the most likely cause of these findings? A. Femoral artery thrombosis. B. Femoral artery embolism. C. Dissecting aneurysm of the aorta. D. Polyarteritis nodosa. E. Thromboangiitis obliterans. The most serious consequence of atrial fibrillation is thromboembolism. Almost 80% of arterial embolisms originate in the heart and the lower limbs. The common causes of these are thrombi originating in the ventricle, following a myocardial infarction, or in the atria in AF. Acute presentation in this patient is more in keeping with an embolism. Patients with femoral thrombosis usually have a history of claudication, and there will be a long history of ischemic symptoms, including rest pain. Aortic dissection usually is preceded by history of hypertension and aortic aneurysm, and rarely with collagen diseases like Marfan syndrome. Common presentation is with chest or back pain, and, on examination, there are unequal pulses when the radial arteries are compared. Polyarteritis nodosa is a necrotizing vasculitis, often involving medium-sized arteries. It usually affects the kidneys, gut, nerves and muscles, often sparing the lungs. Thromboangiitis obliterans or Berger disease is non-atherosclerotic, segmental inflammatory disease of small and medium-sized arteries, veins and nerves of the extremities. It is almost invariably seen in smokers, more commonly with homemade cigarettes with raw tobacco. It usually starts with distal ischemia and ulceration in the digits and then moves more proximally. A 20-year-old man is admitted after a motor vehicle crash, in which he sustained multiple lower limb fractures, for which he required surgery and bed rest. 5 days after admission he is noted to be pale, clammy and short of breath. His BP is 110/70 mm mercury, pulse 100 beats per minute. Which one of the following investigations is most likely to provide the diagnosis of the current problem? A. Duplex ultrasound of the calf veins. B. CTPA. C. D-dimer assay. D. Positron emission tomogram. E. Chest X-ray. Early diagnosis of this young man's probable pulmonary embolism is best achieved by a computed tomogram CTPA, as illustrated, confirming the diagnosis. It has replaced ventilation perfusion lung scan imaging, which is often equivocal where other pulmonary pathology is present. But note that VQ perfusion scan is done among reproductive women and pediatrics. Chest X-ray also is often non-diagnostic. Duplex ultrasound of calf veins may detect DVT, but does not help in the diagnosis of the lung lesion itself. D-dimer assay is similarly only of help in the diagnosis of DVT. Positron tomography can give biochemical characterization of tumors and their pulmonary metastases. Thank you for watching this video. Subscribe to this AMC Clinical Pearls and follows us on Facebook for you to be updated on our latest uploads. All the best to your review and exams.